Okay, welcome to ComplyPlus Presents. We're back in the chairs after a small break. Well, Richard didn't have a break, but I had a break.
How was it?
Yeah, fantastic. Nice break. Refresh, see a different part of the world. So can't complain. But good to be back. Just as the weather's turning, the nights were a bit longer and so on. So yeah, nice time to be in the UK, I think, at the minute. But yeah, we're back together. You hopefully have seen some of our recent editions with some guests, and we've got some more guests coming up.
Yes. So it's not just going to be us.
It's not just going to be us every week.
Yeah.
We're trying to give a bit more variety, get different viewpoints, speak to other thought leaders in the industry as well. So hopefully giving you guys meaningful things to sort of listen to and look out for on our socials. So today we're going to discuss, again, quite a topical matter at the moment in the industry regarding developing effective healthcare training, and we've been discussing this quite a lot in some of the things we've been doing as a business since the start of the quarter. Really, we've been looking at readiness and effectiveness of training quite a bit, and today we're going to look at how you develop effective healthcare training programs, because there's been a few issues in the news, certain organizations, and there's been a lot of talk around this as well, particularly in social media. So yeah, I'm joined with Richard. How have things been at your end?
Busy. I think, as you rightly said, there are a lot of changes in the sector right now. Even if you look at organizations like NHS England, we're still yet to find out how things are going to map out. And it doesn't just affect healthcare, it affects social care as well. Because remember, it's one department of health and social care with one secretary of state. Then the different ministers then for healthcare, for social care, for mental health. And even when you talk to people in Westminster, and we do get access to some of the people in Westminster, some of them are still not sure how things are going to make out and worried even to sort of say, God, because NHS England was such a big presence.
The cornerstone of it, wasn't it?
Managing, nearly 200 billion of funding, budget, and then all of a sudden, when that organization is abolished, when they say that in the news, it sounds like, this doesn't matter anymore.
Just getting rid of a small company or something.
Yeah, but actually NHS England is still working, and even Care Quality Commission, they've had a lot of challenges, but they've got a new chair now, a very experienced chair. They've got new teams. They now have a chief inspector for mental health, and they've moved things around. Their executive team has changed quite a lot. So, and I'm quite confident, actually, because there was a time where you get worried to sort of say, God, if Ofsted are struggling, CQC are struggling, NHS England are struggling, what's going to be what's going to happen to the sector? So, and I think there's a tendency for us to focus too much on healthcare and forget actually what happens downstream in social care in the community. Because if we have fewer beds in hospitals and we want to provide more care in the community, then we've got to train those people. We've got to ensure that they are ready to take patients that usually would have stayed in hospital or gone to some specialist facility or rehab facility, but they're now going straight into the community. So that readiness is where I'm seeing worries. And even when we talk to people in local authorities, decision makers in local authorities, there's a worry that although this is good to provide services in the community and look after people in their own homes, provide them as much support as they need, but actually if the competencies are not there, then that's a problem. So because if you are looking at clinical competencies, and you have a shortage of nurses, you have a shortage of many professions, it's now up to the care workers. How do you train them quickly enough? We were talking about complex care just a few weeks ago. We were going into a partnership with another organization to deliver complex care training. We are responding to the needs of the sector. And the organizations that are supposed to be guiding, they're behind. They're being overtaken by events. And it's left to companies like us to pick up the scraps and then work with providers to get them ready.
Scratch and ready, for what's coming,
but it's exciting times. And I think actually the good thing is, despite the instability, political instability around the world right now, and you can't ignore that, and that's a tendency in our sector as well, health and social care, to pretend that things are not happening, of course, what's happening, geopolitically affects us directly because the government is too busy trying to figure out what to do with geopolitics, and it takes them away from the things that really matter for the country.
Things closer to home sometimes.
Exactly. And then for me, I'm always, it's not nice to listen to the news these days. It's very negative every single day. But we have no choice because somewhere in there's hidden stuff about social care. There's hidden stuff about healthcare.
All that relates to it.
Yeah, so we have to keep sifting through all this so that we get to the bits that are relevant to us. Yeah.
Yeah. Okay. So let's get into it. So why, I think we've already touched on some of these already in the opening segment, but why does training matter in health and social care? Why does it matter? Why do people have to develop these plans and implement them?
Yeah. So when you look at health and social care in the UK, we can use England even. I must say in England, it's now one department. You're dealing with people that have different needs, clinically and socially and other ways, and so there's vulnerability there, and there are outcomes that are expected. Right. So there's a legal requirement, from a duty of care perspective, to ensure that organizations are well equipped. So through training and then ensuring that staff are competent and they can work safely and effectively, and then they meet the compliance requirements from the regulatory bodies. But also there's an element of self-policing for organizations. If you're going to run a healthcare business or social care business, it's not just about how much money you're going to make and how you protect your investment. It's about thinking about the customer. And quite often, the service user is not considered as the customer. And it's a challenge, even academically. There's always discussions to say who is the actual customer. So I think the customer sometimes, the service user, is not served fully because organizations are not equipping themselves fully. Managers and business owners and even big NHS trusts. We were discussing just last week, we're looking at one of the largest mental health trusts in the country that has failed on pretty much everything. And I think if it was a private organization, that would have been shut down because it's unsafe, it's poorly led, it's not providing caring, effective, responsive. So it's failing all of the CQC requirements. And it's one of the largest mental health trusts in the country. They're supposed to have governance structures in place. So the state of the industry right now, and I call it an industry like any other, it could, we are not treating these as businesses that have customers. We're serving ourselves sometimes. So training helps to bring us back to why we are here. That's how I look at it.
Yeah. Okay, so some of the buzzwords used in the sort of training arena, if you like, things like statutory training, mandatory training, CPD courses or hours, quite often used, particularly for people doing revalidation and having to continue their professional development. So, what's the difference? How would you, in layman's terms, explain the difference between those three things?
You're right. They're used interchangeably as if they mean one thing.
Yes.
And whenever, like now, I'm going to some of our clients with our trainers to deliver training, I've ensured that we ask that question. And quite often you're met with blank faces. Even senior people in the organizations do not know the distinction and why the distinction matters. So statutory, in simple terms, relates to the law.
Yes.
So it's training that you need to do by law.
Yeah.
So, for example, Health and Safety at Work Act 1974 and the various regulations that are part of that act require you to do risk assessments in the workplace, assess the risks to the different stakeholders, then provide training, have policies and procedures. So even fire safety order requires you to give fire safety awareness training, then the different levels of training then for people's responsibilities. Mandatory training, on the other hand, is what the organization deems to be necessary training for them to deliver safe and effective care. So on top of the statutory requirements, they do assess their own risks in their organization because every organization has different risks depending on the services that they are providing, so the regulated services, and also the service users themselves, the competencies that are needed for people to deliver those services effectively. So the organization then does a self-audit and then determines which training is mandatory for their staff. Then CPD, that's continuing professional development, we talk about lifelong learning. When I started as a student nurse in 2001, you learn from day one that nursing is not just one, you get the degree and you're sorted. There's lifelong learning. You have to keep improving and develop professionally. It's not just so that you can get promoted and grow in the organization, but actually for you to stay up to date. You need continuing professional development. So what tends to happen there, the impact of people not knowing these definitions and the distinctions between these terms, is that they end up with a list, an arbitrary list that they share around, and then it becomes, that's what we do. Because even the regulator, sometimes they end up with that list and they're ticking a box to say, oh, you haven't got this, you haven't got that. And we've run companies as well in this sector where I would end up getting really frustrated with auditors and inspectors and say to them, look, we are supposed to be assessing our risks, and that risk is law. That's why we have done that. But if you see, this is not on your list, but we were doing it.
We're doing it, yeah.
One classic example is the Oliver McGowan mandatory training, for example, for autism and learning disability. We were providing autism and learning disability awareness all along, right? Because we realized that there was a need. But then obviously when NHS England now decides that this is going to be done, and then they make it an arbitrary thing, then everyone is like, oh, all of a sudden, we need to tick the box for Oliver McGowan mandatory training. And then you think, okay, who was it developed for? That program was developed by NHS England for NHS organizations, right? Does it work then in adult social care? Does it work in private?
Other settings.
And then, how do people even access it now that you've pushed it through Westminster to make it compulsory? Is it now mandatory? Is it statutory? No one is clear. And even when we reached out to try to sort this out, it becomes a real challenge, because if you don't have full guidance on some of these issues, then people end up with a pointless list that does not really meet the needs of the service users, meet the needs of the organizations. They have to tick boxes. And that culture of ticking boxes has to stop. And it starts by actually defining things clearly, then letting organizations actually self-audit based on their needs, based on the services that they are providing, based on the competencies within their teams as well. I can come up with many examples, but those are some of the key issues that I've found personally over the years. Yeah.
And what about CPD then? So we've touched on statutory and mandatory. How would you explain CPD? Because like you say, people clump CPD as mandatory or statutory. Like you say, these terms are all intertwined in some people's minds. So how would you define CPD, and what examples are there for people in our sector, in terms of CPD? What things can they do? How can they achieve it, and so on?
Yeah. So if I take, say, the professional bodies, you look at the Nursing and Midwifery Council, General Medical Council, General Dental Council, HCPC, they expect health and social care professionals as part of their continuing professional development to, yes, mandatory training and statutory training is crucial, but they expect you to do additional training to develop professionally. So it could be something as simple as subscribing to a newsletter where you're updated about what's happening in the sector.
In the industry, yeah.
Maybe people are members of unions, organizations like Royal College of Nursing or Unison. They also provide CPD. You can go to a workshop, you can go to a conference, you can attend a webinar. It doesn't necessarily have to be a course where you get a certificate. CPD hours, again, people are supposed to be self-policing. And then they log and evidence the hours that they have accumulated. But again, when it becomes a tick box, and I know you have dealt with some of these professional organizations as well, where they wanted certificates to look a certain way. And we ended up just agreeing, because obviously for us, if our certificates then are deemed invalid, then there's no point. People are then doing courses that are not going to give them a certificate that meets the needs of their professional body. And I'm glad we've done that, because actually when you have professional bodies reaching out to you, then it means that you matter as an organization and you're providing a crucial service. So yeah, CPD is ongoing professional development, lifelong learning. And you don't just do the mandatory training, mandatory and statutory training. I used to work in A&E, for example, or even in cardiology, or when I worked in clinical research. You learn new things every time, and then you go and read a bit more. So, Okay, I didn't know about this because that patient may be presented in a way that you have never experienced. Then you have to go then and read about it. What we are not good at, or at least from the experience, from my own experience, was logging those hours.
Yeah.
Then we're now in a desperate dash to go and attend some pointless courses quite often so that we can get the hours and submit our documentation
accumulate your hours,
for revalidation. Yeah, so it's another area that is misunderstood, and it needs clarity.
Yeah, because people have to do this, like we were saying about revalidation.
Yeah.
And I know it's something that we're looking to sort of implement with ComplyPlus, but also actually bring in things outside of the mandatory and statutory that these professionals can do, or even attend. Like you say, I think even social media forums now are becoming valid CPD hours. Actually engaging on forums and so on, which we know is very popular at the moment. So in terms of developing an effective healthcare training program, for example, how do you make a start on that? What's the first junction you go to start this process?
So whether you're an existing organization or you're a new organization that is starting out, you need to know what you stand for. Then you register the services, the regulated services that you are going to provide. And each regulated service will have different requirements. So the statutory requirements are fairly consistent. So you're mapping your training to the legislation and regulations, which CQC regulations apply to you. Pretty much all of them will apply to you, but how do they apply to you, right? Then if we are dealing with local authorities or other commissioners, what are their needs? What are their expectations? Then most importantly, what are the needs of the service users? What are the outcomes that you are aiming to achieve? What competencies are there in the organizations? So what I'm describing there is an organizational needs analysis and then a staff training needs analysis. Then once you do that, you are then saying, we come up with a structure on the statutory training, then a structure for the mandatory courses. Then if staff are completely new, how are you going to give them an induction and onboarding? When and how do they do their refresher courses? What additional training do they need on top of the induction? Like in the NHS, I worked mostly in the Midlands, Coventry and Warwickshire, and different trusts in East and West Midlands primarily. You'd get an induction. Everybody gets an induction, what they call corporate induction. So the CEO would come in, or there's a video, then there are people that are talking about the different elements of the organization, the risks and what is expected of you, security features and all those sort of things. Then you then break into different groups, clinical groups, non-clinical, and then maybe professional groups as well. Then you're now doing custom training for your particular profession and the role that you have in the organization. Then you then go to your department and they do the onboarding for the department. So most organizations, NHS organizations to be fair, were very good with this. But when you go to private organizations, especially the small to medium-sized ones, they don't have the structure, the governance structure that is there in NHS organizations. You normally would have the service registered manager who is doing everything. And sometimes they don't even have the competencies to do these things. They have not got the experience, and their organizations do not have the structure. Some organizations do it very well. But again, it's an issue now of knowledge, knowing actually what we are supposed to know. And if you don't know what you don't know, then, it's not going to be relevant, is it? You're going to do things that you think are important for your organization. And sometimes people are blindly non-compliant without realizing it, but it's because they lack the competencies to do those assessments that I've just described. Yeah.
So once you've built the curriculum, how do you go about delivery?
Yeah, so traditionally in the sector, face-to-face training was the way to do things.
Yes.
And you have seen that.
Evolution, really.
Yes. So face-to-face, everything is done face-to-face because things are better done face-to-face.
That's the way it is. Yeah.
Yes. And some organizations, I remember in the mid to late 2000s, there was a trend to have training videos where they are recorded videos of different quality, people lecturing on a video and then doing demonstrations of how to do things. So what used to happen is organizations who sit staff in a room, new staff in a room, get them to watch those videos, then tick, they've done the training. Then some organizations would bring trainers, some organizations have in-house trainers. Then e-learning, we've seen a huge uptake of e-learning, especially during and after COVID-19, because even organizations that didn't believe that e-learning was worthwhile, they were forced now to use it. So there's classroom training. Some organizations are still doing the video training where they record the videos. There's blended learning where you combine different ways. And there's webinars now. People do webinars. There's lunch and learn. So it depends. A lot of organizations, what they tend to do with the statutory and mandatory training, they want to either do it face-to-face or combine it with e-learning. So people do the theory online, or they go and read a booklet, then they come in for the practical. And then they do different levels of assessments. And some organizations have just deferred everything to online, right? And then there's no surprise that those organizations are going to struggle they're not going to deliver their services safely and effectively. And inspectors coming in or auditors coming in will pick on that straight away. Yeah. So you have to decide which courses. Some courses are not suited to be done online completely. The theory can be done online. But the face-to-face, for example, resuscitation, first aid, moving and handling, fire safety, even medicines management. So the organization now has to decide which is the best way to deliver the different kinds of training. There's some guidance from Skills for Health, Skills for Care. But again, it's up to the organization to decide based on their own needs analysis.
Yeah, and any guidance from
exactly.
local authorities.
Guidance is just guidance at the end of the day. It's how you implement it within your organization. Yeah.
Yeah. So once you've made these decisions and training is being delivered and executed and so on, how do you evaluate if that training's actually working? And another common question is, how often should it be refreshed?
Yeah.
Because there's loads of different thoughts on that as well.
Yeah. So there are many different ways to evaluate the effectiveness of training. Part of it is self-audit, where you are genuinely auditing how you are doing as an organization. So even if you go to the Care Quality Commission guidance on how they do their inspections and what they expect on those 5 key questions, and then now with the quality statements as well, it's designed really for you to self-assess, right? Good organizations will be doing audits. How many incidents did we have and accidents or near misses? What are they telling us? Then you may have to restructure your training. Then also, if you look at complaints or concerns, if people are raising complaints and concerns, use them as a way to learn, because that feedback is important. And sometimes the feedback, that feedback we get from dealing with complaints is not used appropriately. People do it to just solve a problem. Then they go back to normal again and then wait for another incident. So it's really crucial. Then you're looking at staff competencies as well. When you're doing your supervision, how confident are they in delivering their work? You can look at documentation. I used to do audits in the hospital where we were looking at patients that had the clots in the legs, so deep vein thrombosis or clots in the lungs. They had an embolism, a pulmonary embolism. And you could always identify where things went wrong. This patient ended up with a clot because when we admitted them, maybe we didn't do the assessment fully. So is it that people don't know? Do they need training? About that? Or do we need to increase the supervision intervals or the staff meetings to update them? Because if a patient gets a clot, 30,000 patients annually die from clots on the lungs, and a lot of those are avoidable, right? And that's part of our duty of care. Even one patient dying, but imagine 30,000 patients annually, right? That's a huge number. And why are we not learning? Because whether it's a GP doing an assessment or whether it's an ambulance service bringing that patient in, there's a criteria that you use. Or if they are going to go for surgery and then they end up with a clot in the lungs or a clot in the legs, it's immobility. If they traveled recently, for how long? What are the risk factors? So there's so many different ways of assessing. And then refresher periods, some of them are mandatory. Like resuscitation, moving and handling, there's clear guidance on when they should be done. Fire safety, there's the annual risk assessment, and there's specific requirements. But when it comes to the mandatory training, it's about organizations being genuinely wanting to improve.
Yeah.
Right. So I go back again to large organizations, including NHS Trust. They have clinical governance leads sitting in boards. Right. You have chief nurse, you have chief medical officer, you have all these people that are sitting, that are at the highest level of decision making, and they're responsible for patient safety and quality. But when you go to the smaller organizations, particularly the independent small healthcare providers, even some of the medium to large ones we have dealt with, you know who I'm talking about here, and the smaller ones, they don't have the governance structure. They don't even realize that they need it. And of course, it costs money when you're going to hire people to come and help you with setting up your governance and maintaining it. Margins are very thin, and training ends up suffering. So we end up doing training to tick boxes, and we're not evaluating the effectiveness of that training until CQC come in, or until there's a huge incident. Then it forces us now to go back and do what we should have been doing all along.
Yeah.
Yeah.
So, what mistakes do you see most often when it comes to training?
The big one is one size fits all.
Yeah, everyone does the same thing.
Yes. So there's a list going around on the internet, there's
in
a
the
list
community
in
or
the
something,
community, and one size fits all. And it's pretty bad because even some of the largest training providers in the country have one course for safeguarding, for example. We have gone further by saying, look, what GPs, people in primary care, dentists need to know, this is the package. Yes, it's still safeguarding course, for example, but this is the package for primary care.
That's relevant
This is the
to them,
package
yeah.
for healthcare. This is package for domiciliary care, for care homes. So one size fits all in the training that we are doing, that list, right? Then one size fits all in the content, actually, right?
Yeah.
Because if I'm going to talk to doctors about resuscitation, for example, doctors can make all sorts of decisions. They can do all sorts of interventions, even at basic life support level, that you wouldn't expect a care worker to make. You wouldn't expect a care worker to know because they haven't gone in medical school and done 5-6 years of medical school, then work under supervision for so many years. So you have to be clear. One size does not fit all as far as health and social care training is concerned. The other issue is over-reliance on outdated guidance. Look, I don't want to be overly critical. I know things have been very difficult lately, but actually we rely on some of the national guidance. And to be frank, some of it is not fit for purpose. You and I know that we are paying some organizations to be approved or endorsed or whatever.
Yeah.
Because, we need that when we bid for contracts. We need to show that we have that endorsement. But is it really worth it? Is it adding any value to what we're doing as a business? So there is a challenge to say, as the sector is poorly governed, the bar to entry is so low as well. Anyone can just set up a training company and then start providing e-learning.
Yeah.
Well, now that people have ChatGPT and other apps, they just quickly put something together without any knowledge of how to design courses properly. That's the other thing as well. Lack of evaluation, lack of adjustment to say, now that I've got this starting list or this guidance, how am I going to customize it for my business? Then poor peer review as well, because they're quick fixes. So even if we're going to do training in-house, do we have the know-how? Can we do the research that is required? Can we actually design training programs? So design is really an issue. Then there's also neglect as far as induction and onboarding, right? People do the same thing. Then when it comes to refresher, they do exactly the same thing. You know that we've had many inquiries about care certificate refresher and think, no, care certificate. Care certificate doesn't need to be refreshed. And even people asking us, are you endorsed or are you accredited by the Care Quality Commission? No, the Care Quality Commission does not endorse or accredit training and education providers. So there are a lot of misconceptions. I could spend a day talking about that, and I get a bit wound up. And I know you guys laugh at me sometimes, but when I get inquiries, because some things come to my desk, to say, oh, what do you think about this? And I'm sort of thinking, God, people that are running quite often big organizations.
Yeah, it's not even the small providers. Some of these are...
They're lacking the real basics that make up actually good governance and compliance, how to run health and social care organization properly.
This is probably a consequence of the rise. We've seen it in other industries and sectors. how things like social media and stuff can influence.
Yes.
Just a couple of people spreading some misinformation or something that isn't actually quite accurate, even though there might not be any malice or harm behind what they're saying.
They think they know.
Yeah, these words then come in like, are you CQC accredited?
Yeah.
Are you affiliated with the NHS? Have the NHS reviewed your training? And you sort of think,
That's not their job.
do you know what these organisations do? That's not a thing. But yeah. And I think, from my experience as well, the one size fits all is a huge problem, where, even people doing, low level sort of care or support work are doing the same courses as someone, as a doctor or
doctors and nurses
nurse.
are asked to do the care certificate.
That's another one that we, even
Yeah.
this year, I've heard people say, well, we've been told we need to get them through the care certificate. And you sort of think, that's insulting to them, if anything. So, I think,
But also, you're wasting time.
I was just about to
making
say,
them
I
do
think
pointless
for
training.
For me, we talk about inefficiencies, and the NHS needs more money, and these sort of things get bandied around by politicians and stuff. But the effectiveness, actually, of how some of these services are being run has to be something that needs to be questioned more. And I definitely agree with that point, that a lot of people in the country right now, even today, will probably be doing training they don't need to do.
Yes. But
they're
yet,
wasting
actually,
time, yeah.
yet when you look at the core skills training framework, because this is a part of the skills councils, isn't it? Skills for care, skills for
Yeah.
health. They do provide guidance. But I don't think people even know that they exist.
Exactly.
Yeah.
So I think it's a case of where do we get this guidance from? How easy is it to access, but also how easy is it to understand as well? Because it's all right saying, well, there's a document on this, and people like ourselves and businesses like ourselves, we know how to interpret these documents and how to use them and how to understand them. And if we're not sure, we know how to maybe get the clarity. Whereas I don't think people coming into this area, particularly business people who are setting up care businesses and so on, do they have that knowledge? Yes, you could argue that there's an impetus on them to learn, because if you're coming into the sector, don't just think it's like any other business. Don't just think you can set it up, get the lowest or cheapest training on the market. Don't vet the staff that are going to do the work for you and so on. But yeah, I still think there's maybe more that could be done there. So yeah, quite a lot of things. A lot of mistakes. I know there's a lot of good things going on as well, but there's a lot of mistakes that I think are avoidable.
But for me, it's almost you go back to the basics to say what does good look like. And I'm thinking of Denise now. She used to say to us, look, if people don't know what good looks like,
how do they know?
How do they know? Last week I wrote an article on LinkedIn based on a conversation that I had with a former, classmate of mine at university. I met him in London, and we were talking. He's coming from commissioning, service commissioning, and he's saying one of the challenges that I face is that I'm dealing with providers who are very good at the business side, bidding for contracts and making money, but they are not educating themselves about the needs of because he's dealing mostly with the care sector, the needs of the care sector. Because you need to understand the governance framework. But remember, we have clinical governance, which started in the NHS, and you find it mostly in healthcare. There is no equivalent in social care, a structure. And we have had to adapt the clinical governance framework for social care because we feel that's a responsible thing to do.
But really it needs its own
Yes,
attention in a way.
but the reason why we are doing that is because we have the know-how. So what he was saying was that people who are coming into the sector need to educate themselves about how the sector works, not just winning contracts, but actually even the clinical outcomes that are expected. There's the common conditions that if I'm running a small domiciliary care company and I want to scale it, how do you build capacity? Well, I'm going to go to complex care because it pays more. But actually, if I don't train people to be equipped to be able to deliver care effectively for people who have complex healthcare needs, it's pointless. Yes, I'll get the contracts, but I'm not going to deliver on the outcomes that are needed for these people, and I'm going to shortchange these people. And then commissioners end up getting frustrated. And the good thing is we used to struggle to reach out to commissioners, but now it's getting easier. And I think there's a mutual respect as well to say, look, NHS England doesn't have all the solutions. Skills for Health doesn't have all the solutions. Skills for Care, the local authorities, because all of these organizations are delivering training as well. So instead of working with us to build meaningful guidance and then supporting us to deliver effectively, they become competitors where it's almost like, oh, this space, you're not allowed to come into this space. Well, and for me, it's very wasteful, and it's backward thinking as well, if I may say, because you need the whole ecosystem. When I look at a health system or a health and care system, everyone matters.
It's got to be inclusive.
It's got to be inclusive. And the reason why we also are in this space is because we feel that we can do things differently. We can make a difference. And there needs to be more collaboration. And I challenge because a lot of people that I know that I used to work with, I've done 25 years now in this sector. So some of these people are now in the most senior positions, leading organizations, making decisions. And when I talk to them privately, I do challenge them to say, look, but you guys need to, well, when I say guys, by the way, I mean, I use that as a common term for everyone. You need to look at the whole ecosystem. It doesn't mean that private companies are here to make a profit off the NHS and make money out of the public sector. We can bring efficiencies. We turn things around much quicker, much cheaper, and quite often more efficiently than most of these public bodies, right? Because we have learned to live within our means. We have learned also to to understand the practicalities of building these systems, building these programs, and deliver them effectively. And we should have an equal, a seat at the table, because if you're working from the margins, it's easy to band people together who are on the margins and brand them. Maybe one provider failed, then you band everyone to say, oh, they're useless or whatever the case, right? But actually, the kind of change that happens in the margins is crucial because it can inform the center, right? We can't do everything from the center. We have to involve everyone in the ecosystem, all the stakeholders. Then we come up with proper governance structures, proper compliance structures, proper regulatory structures that mean that we capture everyone's concerns, but also we value everyone's contributions in the sector. And I think that is the biggest challenge that we have. But I've got a feeling we're going in the right direction. And even by the time the government is finished consolidating whatever is going to be left of NHS England into the Department of Health and Social Care, we'll be better informed. And it will need to be very clear what Skills for Health stands for, what Skills for Care stands for, what local authorities, what powers do they have, and how do we regulate the sector as well meaningfully. I know with qualifications we have Ofsted, we have continuing professional development, accreditation with peer review. There are good things that are out there, but right now I just feel that the regulation is substandard as far as training and development is concerned. Right? There's too much box ticking, and there's no allowance for organizations to determine what they should be doing, because most people that are running businesses, they're genuine people that are willing to learn and then do what needs to be done. But then they're constrained by outdated ways of thinking and outdated systems that don't allow innovation. Yeah.
Okay, excellent. So hopefully everyone's, all the listeners have took something from that and can maybe resonate with some of the things we've discussed. Just a couple of things before we let you go. We will be putting some materials and tools out to help people with this.
Yes, definitely.
Because we realise that it's not maybe as easy as it sounds or as it seems. So we've got some really interesting templates, checklists, different tools that through our ComplyPlus system you'll be able to utilise free of charge. So yeah, please make use of them when they come out. You should see them throughout the month of May. We'll be pushing them a lot on socials and through our website, and also to existing clientele as well, to make sure that these things have to be updated. as we've just been saying for the last 30 minutes or so. So yeah, keep an eye out for those. We'd love to get any feedback on them as well, if they can be adapted. If you've got other ideas or insights or challenges you've dealt with in your business, feel free to reach out to our teams, whether through direct message or through social media. And yeah, we'll see what can be done. But really excited about getting those on the market for everyone, and hopefully they can make a difference to your business as well.
But also questions are crucial. If you have any questions for us, or you've got topics that you want us to discuss on the podcast, you're more than welcome. And also if you want to be a guest, because I quite enjoyed when you were away, I quite enjoyed
someone else's company.
Somebody else. Not that there's anything wrong with your company, but I think it brings a different perspective.
No, it's what's needed. Like we were saying when we first started this podcast towards the end of last year. So we've got 2 more guests, I believe, lined up for May. But as Richard rightly said, if you're running or if you're working in the health and social care sector, or running a business in health and social care sector, we'd love to hear from you, get your perspective on where you think things are.
Regulators as well.
Regulators,
regulators, commissioners.
There's no holds barred. Anyone who wants to come on that feels they can and have a good discussion with myself and Richard, please feel free to reach out to us. So and as always, feedback welcomed on this episode, or if you've got any other thoughts to add, any questions, just comment on our social media posts or reach out to our team, and we'll do our best to get through them. But otherwise, we'll be back next week for another edition, and enjoy the rest of your week.
Goodbye.